So today we're going to be talking about headaches and two types of headaches. Basically, we'll talk about tension type headaches and we will talk about migraines. The recording for the last class, I will send you the link by tomorrow. I recognize that there's still something patently wrong with the LMS at this time. You can access it, but I think last year's lectures are still up. I'm still awaiting information to see if it will be archived so we can move on to something different, right? But I know by the end of this week, we should have information about that. But then in the meantime, I will send you the links to the video recording and also the lecture note I'll share via mail with your class. So just to get into it, headaches are well known. It's a kind of pain that people experience in their heads or around the head. Tension type headache is the most common, and everyone would have experienced it at one point or the other, either in relation to stress, strain, disease. For some people, they even have frequently occurring headaches that, over a period of months or years do not absolutely go away, but recur now and again. Most headaches are thought to originate from myofascial factors, that's the muscles around the face, including the nerve endings that sometimes may get inflamed, and the peripheral sensitization of receptors. Those are the nerve endings around the face that can sometimes get inflamed. There's also something called referred pain, which is when you have some muscle tightening in other distal parts of the body that results into sensitization of the myofascial muscles and the nociceptors in the face, resulting into a headache. So that's why sometimes pain relievers that do not have anti-inflammatory properties tend to relieve headaches, some types of headaches, and sometimes they do this basically not from the anti-inflammatory properties, but from relaxing the muscles themselves. Okay, so central mechanisms are involved, essentially the brain centers. Like I mentioned, mental stress, non-physiologic motor stress, local myofascial release of irritants, or combination of these may be the initiating stimulus. A clinical presentation of a headache is usually premonitory symptoms and aura are absent. Premonitory symptoms and aura, they're common with migraine patients, and premonitory symptoms are different from aura. Premonitory symptoms may occur for a short while or, classically before the headache happens, while aura sometimes lasts an hour before. Please mute your mics.
Oh, shit.
Okay. So both of these are absent in tension type headaches. The pain is usually mild to moderate, bilateral, non-pulsatile, and happens in the front of the head. You always know when it's a regular headache and it's different from a migraine. Most people describe migraines as being localized or, to a part of the head, right? Light sensitivity may also happen with headaches, but they are very much different from the intensity of light sensitivity that happens with migraines. Okay. In terms of treatments, you can have non-pharmacological, and then you can also have pharmacological treatments for tension type headaches. That's normal headaches, as you would say, right? So usually it involves reassurance and counseling, stress management, relaxation training, and biofeedback, because this kind of headache, this particular kind of headache, can usually be resolved by rest, since they are often caused by stress. So anything to resolve the stress or the muscle strain that causes it will usually resolve the headache. So things like you can use physical therapeutic options like cold. That's why sometimes if you have a headache, your parents may have used something like ice pack, put them on your head, and then you feel some sort of relief, right? So these work. Sometimes some people use acupuncture if it's moderately severe, but they still do not want to use medicines. You can also have, you can use TENS, which essentially do nerve stimulation, right? Those paddles that you put on the sides of the head that send minimal electric shocks through the skin to the nerves underneath the skin, right? So you can use them as well. They're not like, there's no evidence in the literature to show that they work consistently, but then they can be used as well in addition to pharmacotherapy. Pharmacotherapy is usually, that's the treatment with drugs, is usually through the use of simple analgesics like paracetamol, Nsaids like aspirin, diclofenac, ibuprofen, naproxen. Those are classic Nsaids. Diclofenac, ibuprofen, naproxen, ketoprofen, ketorolac. Those are classic Nsaids that, their safety profile is well known. Their sensitivity is also properly documented, so they are safe when used, in the treatment of well-known patients, right? If the severity of the headache is much more than mild, for example, if it's moderate or severe, of course, you can use a combination of NSAIDs with other medicines. For example, you can use combination of paracetamol with codeine. You can use butalbital with paracetamol, right? These are used in moderate to severe headaches, right? And it's advisable that since most of these are given over the counter to treat this type of headaches, it's advisable that their duration should be short and not more than the recommended periods in a month. There's no evidence to support the use of muscle relaxants, even though they're still currently in use. Even though there is the evidence that referred pain may contribute to incidence or propagation of headaches, muscle relaxants do not necessarily have any evidence in literature to show that they work, right? So the use of the simple analgesics are enough to resolve all headaches, that are tension type headaches. Consider preventive treatment if the patient has more than 2 episodes per week. So usually you'd look at what causes the headache for this person, or what are the triggers for the headache, and then you medicate when those triggers, when the patient is exposed to those triggers. Those triggers can be food, it can be spices in food, can be things like even activity, maybe exercise, emotional distress, sexual activity, could be menstruation, depending on what the trigger is. You medicate the patient around those to serve as prophylaxis. Tricyclic antidepressants are used most often for prophylaxis of tension headaches, but then their side effects are a limiting barrier. Now we'll quickly talk about migraine headaches and some of the treatments around migraine headaches. Tension type headaches, like I mentioned, are the common headaches that people experience with relations to disease, stress, and other discomforts. Migraines are different. They're very common, but they're different from the regular headaches. They're recurrent, and they're primary headache of moderate to severe intensity. Migraines are never mild, even though sometimes we tend to ask patients to graph their pain on a scale. Sometimes you are told, if anybody here has been to a doctor that's treating you for a migraine before, they ask you to grade it from 1 to 10 or from 0 to 100, or maybe use a couple of smileys to indicate how you're feeling, right? Even if you grade your migraine as a 1, right, the physician knows that you grading it as a 1 does not mean that your migraine is moderate. Does not mean your migraine is mild, right? There's a principal understanding that migraines are usually life-altering. So they're, moderate to severe intensity, interferes with normal functioning, and is associated with GI, neurological, and autonomic symptoms. Some patients have aura, and in those people, the aura, I will describe what the aura means shortly. In those patients that have aura with the migraine, focal neurologic symptoms precede or accompany the attack. You will see that distinction as we go forward. The main pathophysiology for this, for migraines, is activation of trigeminal sensory nerves that triggers the release of vasoactive neuropeptides, including the calcitonin gene-related peptide, neurokinin A, and substance P. These are the neuromodulators that help us to sense pain, right? Most of these are released from the perivascular axon, right? It can also be associated with vasodilation of dural blood vessels. And following that, you may have extravasation of dural plasma. Extravasation, of course, you know what that means. That's movement of fluid from inside the blood vessels to outside the blood vessels, right? So you can have extravasation of dural plasma resulting in inflammation in the brain tissue, and that propagates the migraine even more. 2 studies have shown that migraines are heritable, right, with multifactorial polygenic bases. That means a number of many genes are responsible, many gene sites are responsible for coding this heritable trait, okay? And the migraine triggers may be modulators of the genetic set point that predisposes to a migraine headache. You will see some of those triggers shortly. Specific populations of serotonin 580 receptors also appear to be involved in this pathophysiology. And of course, it's one of the primary targets that we exploit in the treatment, or that's in resolving migraine headaches. So for example, most people in this class would have heard of ergot alkaloids, right? Maybe fewer have heard of triptans, but definitely a lot of people would have heard of ergot alkaloids. These are agonists of vascular and neuronal 581 receptors. And what they do is once they are taken in, it results in vasoconstriction along the pathophysiology of a migraine. Is that the inflammation that results from vasodilation of dural blood vessels still causes further vasodilation, resulting into more pressure in the brain, resulting into more pain that leads to more inflammation. As there's more inflammation, the blood vessels dilate more and end up causing more harm, right? So ergot alkaloids triptans, they cause vasoconstriction, inhibition of vasoactive neuropeptides, and try to resolve the inflammation being experienced. Now, on to clinical presentation and diagnosis. Migraine headache is characterized by recurring episodes of throbbing head pain, and this is frequently unilateral. That's a major difference between migraine headaches and tension headaches. Tension headaches, remember we mentioned that it's frequently bilateral, and then it's non-throbbing as well in nature. Most patients who experience migraine talk about it being localized to a particular part of their head or of their fascia, right? Also, you have a number of inconsistently, but then there's a large number of people who have premonitory symptoms in the hours or days before their headache starts. Premonitory symptoms include phonophobia, so they are sometimes disturbed by the noise they hear, light, they may complain of light sensitivity, right? They may smell certain incenses or odors particular to them, and they may have difficulty concentrating, right? There could also be psychological symptoms like hyperactivity, restlessness. You could have diarrhea, constipation, and it could also be things like food craving, anorexia, thirst. All these are regarded as premonitory. These happen hours or days before the migraine itself happens. The aura is experienced by a fewer number of migraineurs, but it evolves over like 5 to 20 minutes and lasts about 60 minutes for an hour. For patients who have this, it can be visual and it could be negative. So, for example, visual includes scintillations. Some people see visions as well. And for some other people, it could just be they have a certain sense of impending doom, right? So all these combinations are they come together to make up what's called the aura. Aura is also specific to different migraineurs. Different people have different ways that they explain, what is specific to their own migraine. Sensory and motor symptoms such as paresthesias or numbness of the hands and face, dysphagia or aphasia, weakness, and hemiparesis may also occur. Patients who have or who experience hemiparesis may have neurological undertones as well. Migraine headaches may occur at any time, but usually in the morning. Pain is gradual in onset, peaking in intensity over minutes or hours, and will last usually over 4 to 72 hours. Sometimes migraineurs have a single headache lasting for 2 to 3 weeks at a time. Okay. Pain is typically in front of the head and moderate to severe. Now, once the headache pain reduces, the resolution phase starts, and that is usually that phase is usually a phase where the person feels weak, they feel spent, and they need to recover. For diagnosis, essentially, it's imaging sometimes is required, but doesn't help. Imaging only helps if the person has had probably been involved in an accident where they hit their head or something like that, or maybe they have a mass in the head. That only helps you differentiate that it's the headache is due to maybe a hematoma or something different. But for migraines, there's really no difference, except there's some neurological basis. There's really no advantage. Okay, that's for diagnosis. I mean, nobody will worry you about diagnosis. Essentially, the focus for you as pharmacists in training is treatment, recognizing the symptoms, clinical applications of these, and how to manage the patient themselves. Okay, so let's talk about treatment of migraines. What's the goal of treatment? The goal is to achieve consistent, rapid headache relief with minimal adverse effects and symptom reoccurrence. Minimal disability and emotional distress, thereby enabling the patient to resume normal daily activities. This is sometimes possible, sometimes impossible. Some patients, in 365 days of a year may have migraines for as much as 2/3 of the entire year, right? So it's a debilitating condition. Ideally, patients should be able to manage their headaches effectively without visiting the hospital frequently. But because some of the medicines that are used are prescription-only medicines, so if they have already stabilized, they already understand, or they've been educated, if the patients have been educated about, the prophylaxis, identifying triggers, avoiding them, and managing their stress, usually you will be able to manage it, probably a few clinical visits in a year. But, since it's a chronic disease, patients will usually be able to manage themselves. There's also the problem of medication use headache. Medication misuse if the patient is using more than is recommended, but medication use headaches can occur even when the patient is using their medicines at therapeutic levels, and it's just part of the pathophysiology. Some patients who have gotten adequate relief and on maintenance dose may suddenly develop medication-related headaches. That's when you withdraw the medication, resolve on its own. Okay. Treatment can be non-pharmacologic and treatment can be pharmacological. We'll see shortly. Non-pharmacological management essentially is similar to tension type headaches, except for the behavioral intervention. You apply ice and recommend periods of rest or sleep, usually in dark environments. Identify and avoid triggers, similar to that for normal tension type headaches. Food triggers to avoid include alcohol, caffeine, chocolate, fermented and pickled foods. Monosodium glutamate is a serious food trigger for certain patients. Foods that also contain nitrates, like processed meat, like ground beef, can also trigger headaches. Saccharin for some patients as well. Foods that contain saccharin can trigger headaches. Environmental triggers include glare or flickering light, altitude, loud noises, strong smells and fumes can also do that. Tobacco smoke as well. Then the behavioral physiologic triggers can include excess or insufficient sleep, fatigue, menstruation, sexual activity, skipped meals, strenuous physical activity, stress or post-stress as well. This can, result into, this can trigger migraine. Now, also, behavioral interventions are non-pharmacological, so they fit in here. They can include things like relaxation therapy. Like relaxation therapy can include yoga, can include meditation, can include biofeedback, cognitive therapy. Cognitive therapy is a specialist practice where somebody talks you through, possibly your migraine is related to a traumatic experience. Somebody talks you through a model that helps you fix the problem and get over the migraine. It's useful for patients who prefer non-drug therapy and when drug therapy is ineffective or side effects limit its use. Now, let's quickly look at the pharmacological treatment of migraines. Pharmacological, of course, means that the use of drugs in the management of migraines. So first starts with this is a decision tree for the management of migraines. Starts with diagnosis of the migraine. Once you diagnose patients with migraine, the first step is patient education. You educate the patient regarding general wellness programs and avoidance of trigger factors. Most patients do not come to you knowing all of their triggers. So you spend a little time with them, asking them to journal, right? So you give them a diary where they write down what they're experiencing from day to day. In fact, it's one of the ways that you are able to differentiate between what their premonitive symptoms are, as different from what their aura symptoms are. So you are able to identify that. Then also their trigger factors, what they've eaten. They have to journal all of those things. Their eating, their activity level, their perception of stress, their emotional state, and all of that. Use all of these to identify their trigger factors. Then assess headache severity. Usually, headache severity is a subjective exercise, even though sometimes you use a pain scale to try and bring in objective measures, but it's essentially a subjective experience. Also, specialists who treat migraines are trained to listen more to the patient. Since the patient is the one experiencing the migraine, they listen more to you and try to understand, your tolerance level for pain. They try to understand your perception of the pain and how, if you think it's a useful pain or if you think it's a useless pain, because that also helps direct treatment in the overall analysis. They also want to know how frequently you're having the headaches, if it's just one-off or if it's all of the time. So that helps to also decide if there's a need for prophylactic pharmacotherapy. Now, if your migraine is associated with severe nausea or vomiting, there's a first point where you pre-treat the patient with antiemetics. Consider use of suppository, parenteral, or intranasal formulations. These formulations are better used because, of course, if someone is vomiting and you ask them to use an antiemetic, they may actually vomit the antiemetic, and then you're back to square zero, right? So pre-treating with antiemetics have preparations that, suppositories, parenteral or intranasal formulations available for the patient. If that helps, then you begin to consider the pain symptoms, right? We mentioned that there's no mild pain related to migraines, right? This is only relative. In terms of mild to moderate migraine symptoms, simple analgesics are still useful. So, for example, use acetaminophen, or you use Nsaids, ibuprofen, naproxen. But if you do not get adequate response when you've dosed adequately at that level, then you use combination analgesics. A combination of paracetamol with aspirin and caffeine. What's the name of? There was one that was really popular at the time. I will try and remember the name before the end of this class. Okay. So this formulation is usually effective. In fact, in most cases, it's actually the first line. This combination analgesics for non-migraineurs, it's the first line. Of course, there are limitations to its use, side effects. Uh, it can start a PUD in patients, right? So all of those side effects limit its use, but of course, they're the first line. It's over the counter. It's easily accessible. Patients can reach for it. If that's inadequate, then it's similar. It means the patient is having severe symptoms at that point, right? So we think about using triptans, or if the patient is not responsive to triptans or cannot tolerate triptans because of one or other treatment they are currently using. For example, if they are on nitrates as well, then you administer dihydroergotamine or ergotamine tartrate, right? Dihydroergotamine uh, is more better absorbed, and it's well tolerated by a number of patients. And if that's not effective, then you look at a combination, a combination of Nsaids with triptans or Nsaids with dihydroergotamine, or a combination along the tree, at low doses, and then scaled up gradually to get effective treatment for the patient. Let's talk about analgesics, the Nsaids and analgesics. For most patients, let me just mention before we go on to talk about analgesics that frequent or excessive use of acute migraine medications can result in increasing headache frequency, right? And this, please mute your mics. Okay. Frequent use can increase the frequency of headaches and also worsen the type of headaches that you have. So it's important that you do not use the what's it called? Don't use the reliever medicines, until when you need them. Very, very important. So let's really talk about analgesics and anti-inflammatory drugs. Simple analgesics and Nsaids are first-line treatments for mild to moderate migraine attacks. Some severe attacks are also responsive to these simple analgesics, but it's important that if you do not get relief quickly, then you move on to the combination of paracetamol with aspirin and caffeine. Okay, Nsaids appear to prevent neurogenically mediated inflammation in the trigeminal vascular system by inhibiting prostaglandin synthesis. That's the basic mechanism of action for Nsaids, right? Inhibition of prostaglandin synthesis. In general, Nsaids with a long half-life are preferred since dosing is less frequent, right? If the patient is vomiting, you can also use rectal suppositories. Just give me a minute, Mike D. Once we're done with this slide, I will take questions, okay? The combination of paracetamol, aspirin, and caffeine is approved for as first line, right? So it's important for for resolution of headaches. Mike D, go ahead with your question. Hello. Okay, let's go on. The second class of medicines is ergot alkaloids. I had mentioned that ergot alkaloids ergot alkaloids are useful for managing migraines. They're useful for moderate to severe migraine attacks. They're non-selective 5-HT1 receptor agonists and that constrict intracranial blood vessels and inhibit the development of neurogenic inflammation in the trigeminal system. Venous and arterial constriction occurs, right? They also have activity at dopaminergic receptors, even though dopaminergic receptors are not indicated in the formation of a migraine. They may be involved in the propagation of the migraine. And so ergot alkaloids are really very important for resolving migraine headaches that are very painful, right? Ergotamine tartrate, there are two congeners that I mentioned here, ergotamine tartrate and dihydroergotamine. Dihydroergotamine is available for intranasal and parenteral or subcutaneous administration, while ergotamine tartrate is available for oral use, oral and rectal preparations containing caffeine, enhance absorption, and potentiate analgesia. It is not all preparations of ergotamine tartrate that come with caffeine. Please note, most of what is commonly available in Nigeria is plain ergotamine tartrate, right? So there's a specific formulation that contains the caffeine. I'm not sure it's registered in Nigeria, but then we also have other caffeine formulations that can be co-administered with this. The main side effect is nausea and vomiting, and this also limits the use of ergot, since one of the major side effects of one of major clinical manifestations of migraine is nausea and vomiting. So this worsens that side effect. So it's important that you pre-treat patients that you're giving ergotamine alkaloids, pre-treat them with antiemetics before dosing them with any of the ergot alkaloids. Contraindications: don't use ergot alkaloids and triptans within 24 hours of age. Also, renal and hepatic failure patients cannot use ergot alkaloids. Patients with coronary, cerebral, or peripheral vascular disease cannot use ergot alkaloids. Patients with uncontrolled hypertension, sepsis, and women who are pregnant or nursing cannot use ergot alkaloids. Izu, go ahead. Do you have a question? Okay. The hydroergotamine does not appear to cause rebound headache, but dosage restrictions for ergotamine tartrate should be strictly observed to prevent this complication. That's the rebound headaches. Now, let's talk about the third group of medicines used for managing migraines. Those are the triptans or serotonin receptor antagonists, like sumatriptan and others, right? The triptans are appropriate first-line therapies for people with mild to severe migraine, or as rescue therapy when non-specific medications are ineffective. Now, patients in Nigeria, we don't use triptans as first line in Nigeria. Triptans are usually used as second line in Nigeria, meaning that they are used after analgesic combinations have not been useful. Okay, triptans are not used until you have at least used a combination of analgesics. They are selective agonists of the 5-HT1 1B and 5-HT1D receptors. Relief of migraine headache results from normalization of dilated intracranial arteries. Remember that we mentioned that when migraines are forming, the arteries in the brain are dilated, right? So this normalizes that and reduces them, that constricts them. There's also inhibition of vasoactive peptide release. So inflammation is also resolved, and inhibition of transmission through second order neurons ascending to the thalamus. Okay, so all it does basically is resolve the migraine by resolving the ongoing milieu of inflammation, dilation, and the response of pain neurotransmitters. Okay, sumatriptan SC injection is packaged as an auto-injection device for self-administration. I have not seen sumatriptan SC self-injector in Nigeria before. The tablets are very commonly available, but they are only available on prescription because they can also be addictive. Okay, so that's one of the challenge of using sumatriptan. It can become addictive, and some patients may begin to use it for that feeling of it gives a feeling of a, you feel like you're doing good, you feel well and calm, like nothing is going to shake you. So that feeling, some patients end up overusing their medicine, and it's harmful in the long run. Second generation triptans, all except sumatriptan have higher oral bioavailability and longer half-lives than oral sumatriptan, which could theoretically reduce the headache recurrence. Like we said, if you use triptans more frequently or any of these medications, it can increase the frequency of the headache. However, comparative clinical trials are necessary to determine that relative efficacy. That aside, all triptans are considered equipotent. Okay, so lack of response to one triptan does not mean that another one will not be effective for that same patient. Side effects that you can commonly expect from the use of sumatriptan: paresthesias, fatigue, dizziness, flushing, warm sensation, and somnolence, right? Okay, we'll still have time. Now, minor injection site reactions have been reported with subcutaneous use. Those who, when it's in a nasal spray formulation, nasal discomfort may also occur. The mechanism of these symptoms is unknown, but a cardiac source is likely. This is for some patients do not tolerate sumatriptan. When mean don't tolerate sumatriptan means that when they use it at therapeutic doses, they experience chest tightness, pressure, heaviness, or pain in the chest, neck, or throat. And some people may actually feel like they are choking. Okay, for those patients, the mechanism that triggers this is unknown, but it's likely related to a cardiac source, and it can be isolated cases of myocardial infarction and coronary vasospasm with ischemia as well. So this is why it is thought that it may be related to cardiac source, right? Absolute contraindications include patients with ischemic heart disease, since sumatriptans can worsen, triptans in general can worsen heart disease. So all patients with heart disease, should watch out for that, and pregnancy as well. Triptans should be used cautiously in patients at risk for unrecognized coronary artery disease. You do a cardiovascular assessment before giving triptans to postmenopausal women, men over the age of 40, and patients with uncontrolled risk factors, for example, uncontrolled hypertension. So the next class is opioids. Opioids and their derivatives are usually reserved for moderate to severe infrequent headaches where conventional therapies have not been useful or contraindicated. The reason is one, opioids will only reduce the pain, and then the frequency of use of opioids, makes it undesirable in this group of patients, since it can easily lead to dependence, and from dependence lead to addiction in this patient class. Okay, so it's important that opioids are used sparingly, they are used with observation, and they are also used with consistent review. No patient should be on long-term opioid therapy for migraines when they're not like terminally ill patients. Now, some people have migraines, like I mentioned, for almost 2/3 of the year, or sometimes as long as the entire year. So for such patients, and also patients who experience frequent episodes of migraines, they can benefit from prophylaxis. Prophylactic therapy is usually administered daily to reduce frequency, severity, and duration of attacks, and to increase the responsiveness to acute therapy. So, for example, patients who use prophylaxis may require smaller doses of their reliever medicines, their preventive medicines, and then their reliever medicines. So they will need lower doses of their reliever medicines. In prophylaxis, you should consider, you should consider prophylaxis in the setting of recurring migraines that produce significant debilitation. For example, patients who have migraines and cannot go to work for long periods of time, or they have migraines and depression alongside, or they have frequent attacks requiring medicine more than twice per week, right? This is important. Prophylaxis can help those kind of people, to avoid neurological injury and limit the number of attacks they are exposed to. Prevention may also be given intermittently when headaches occur in a predictable pattern, right? For example, if the migraine is associated with exercise, or the migraine is associated with menstruation, for example, okay, this is when this will happen. So I can begin to take some prophylactic therapy before the event occurs. So if the event is predictable or the exposure is predictable, then prophylaxis is recommended. Efficacy of many of the prophylactic agents are also similar. So essentially, what you will look at is be sure that the side effects profile does not, worsen something else that the patient is using. Once you are able to, once you're sure of that, I think you can initiate, prophylaxis in that patient. The only preventive that is that's currently approved is actually they are beta blockers. Sorry, what am I saying? What's the name of this thing? Timolol. You have timolol. You have divalproex sodium. You have topiramate, and you have propranolol. Yeah, those are the ones that have been approved for the use of prophylaxis because one, they have fewer side effects. They have fewer side effects compared to others that have been trialed in clinical trials, and then also they show some level of efficacy. It's best to initiate prophylaxis at a low dose, and then continue for 6 to 12 months, before you begin to notice any reduction in the frequency of the headaches. So the patient should be educated that even though you initiate prophylaxis, it will take about 6 months before appreciable difference is noticed. So this table helps see how you can either have what's it called, a compelling indication for for the treatment, or you can just go down this line. I mean, from this set has the least number of side effects down to when it becomes more complex. Okay, it's very easy to follow. So, for example, like I mentioned, if there's a predictable pattern, you can initiate NSAID or triptans at the time of vulnerability. Healthy or comorbid hypertension or angina, you can test beta-adrenergic antagonists, for example, verapamil. If there is comorbid depression or insomnia, you can try tricyclic antidepressants. If there's comorbid seizure disorder or bipolar illness, you can try an anticonvulsant. If that's ineffective, you can introduce verapamil. Okay. And then if this is ineffective as well, you consider combination therapy. The idea, like I said, is to ensure that you're giving the patient the medicine with the least number of side effects, since the condition itself comes with appreciable debilitation. Now, talking about beta-adrenergic antagonists that are useful, propranolol, timolol, and metoprolol, they reduce the frequency of migraine attacks by almost 50% in half of patients. Okay, atenolol and nadolol are probably also effective, but they have not been approved for use in prevention. The question now arises that if a patient is hypertensive, and has migraine, and is currently on atenolol, for example, in their treatment, should you substitute atenolol for propranolol, or which is less effective, or for timolol, which is less effective? Of course, the logic would be probably to continue with the atenolol, or to switch the patient to metoprolol, which is as effective in the management of hypertension as atenolol as well, right? Rather than switch the person to something like propranolol, right? So equivalents are also available when you're thinking about compelling indications. Beta blockers with intrinsic sympathomimetic activity are ineffective. Bronchoconstrictive and hyperglycemic effects can be minimized with beta-1 selective beta blockers. The side effects you most likely see in these patients that are, since like we said, the treatment is usually long-term, from 6 months to a year, right? So you usually see drowsiness, fatigue, sleep disturbance, vivid dreams, memory disturbance. These are classic beta blocker side effects that you see with treatment with beta blockers, right? I'm sure you guys have talked about some of these drug classes in is it? No, it's not physiology now. I think it's in pharmacology. Yeah, you would have talked about this classic side effects for drug classes, right? So these are classic side effects seen with beta blockers.
No,
Sorry?
sir, we have
not done it, sir.
You've not done drug classes in pharmacology?
Yes, we haven't.
Okay, so just note that these are the classic side effects seen, broadly across with the use of beta blockers. Drowsiness, fatigue, sleep disturbance, vivid dreams, memory disturbance, depression, sexual function, sexual dysfunction, bradycardia, and hypotension. Since beta adrenergic drive is usually required for activity, for that energetic, move that you have as a human being, right? So when you block those actions, you have drowsiness, fatigue, you have sleep disturbance, the sexual dysfunction. You understand? It should be used with caution in patients that have heart failure, peripheral vascular disease, atrioventricular conduction disturbances. Those are patients that may have pacemakers already inserted in their hearts. It should also be used with caution in people with asthma, since this may trigger their asthma. It should also be used with caution in patients with depression. Remember that one of the side effects is depression. So it can worsen depression in patients. And then also it can cause numbing in patients with diabetes. It may not allow a diabetic to identify that they're already going into hypoglycemic shock, and then suddenly they crash and die, right? So it's mostly contraindicated in people with diabetes. Also, antidepressants are used in the tricyclic antidepressants. They are useful in prophylaxis. Tricyclic antidepressants like amitriptyline and venlafaxine are probably effective for migraine prophylaxis. We're saying probably effective because there is no clear clinical data showing that they are very effective for migraine prophylaxis. They're almost as similar as the effect you get from using what's its name, Nsaids, right? So there's not enough data to support that they are efficacious, but they are still useful anyway. Their beneficial effects are independent of the antidepressant activity, much more related to downregulation of central 582 and adrenergic receptors. Tricyclic antidepressants are usually well tolerated at the doses used for migraine prophylaxis, but anticholinergic effects limit its use, especially in elderly patients or those with benign prostatic hyperplasia or glaucoma, right? For patients in general, evening doses are preferred because it causes sedation. You may also notice some patients will complain about increased appetite and weight gain after a while, and then orthostatic hypotension and slowed atrioventricular conduction are occasionally reported. This is common in patients who have heart disease. So you need to watch out for these in patients who have migraine and also have heart disease. Phenelzine is also an example in this class, has been used for refractory headache, but it has a complex side effect profile. So best to just stay away from phenelzine entirely. The last class we'll talk about is Nsaids. These are modestly effective for reducing frequency, severity, and duration of migraine attacks. But the limiting factor is the GI and renal toxicity that limits its prolonged use. As simple as using ibuprofen or diclofenac, for 2 to 3 months, reducing severity and duration of migraines. But it's also important to note that patients who may appear to tolerate it, if you check their clinical markers, for example, their renal markers may begin to show that they are already suffering toxicity. So it's important to continue to monitor patients who are on prophylaxis when you are using when you're using Nsaids. For migraine prevention, evidence for prevention is strongest for naproxen and weakest for aspirin. Other drugs that can also be used for prophylaxis include verapamil, used widely, but evidence is scarce. Other triptans, frovatriptan, is effective for prophylaxis of menstrual migraine. Niratriptan and zolmitriptan are not as effective as frovatriptan. Other medications that can also be used include petacites, riboflavin, extract of feverfew, subcutaneous histamine, lisinopril, candicertan, clonidine. These have been tried, but of course, there's need for more research to show that they are effective. It's also important as we round up this section to talk about evaluation of therapeutic outcomes. You see, in most cases, we give patients medicines and we leave them on their, to their own devices. We do not follow up to know how well they are doing on those medicines. And this is important because medicines used to treat migraine, as well as medicines used to treat common headaches, they are very toxic when patients are exposed to them in the long term. Take, for example, frequently used Nsaids, and simple analgesics can result into renal dysfunction, renal failure, and even death for patients. So it's important that, we institute mechanisms to monitor the patient's use of the medicine, and then to also monitor how well they've complied with the safe use of those medicines in the long term. Okay, so when they're coming for their reviews, you check their adherence, you check how well they are using their prophylactic treatment. Then you also, of course, also monitor their liver enzymes, kidney function tests, and be sure that nothing in that range is calling for attention. Okay. James is saying you're just in year 3. I don't understand. Okay. So monitoring for frequency, intensity, and duration of headaches, and for any change in the headache pattern is important, right? It's the responsibility of the pharmacist to do this. You encourage patients to keep a headache diary to document the frequency, the duration, and the severity of their headaches, headache response to the medicine, and potential triggers of migraine headaches. Okay. You also monitor patients taking abortive therapy for frequency of the use of prescription and non-prescription medication and for side effects. Aside from using medicines like the triptans, using ergot alkaloids, some of the patients will also use the non-prescriptive medicines like paracetamol. They also use Nsaids alongside. So you need to be able to monitor both of these, that the patient is using. Also, they have to document the patterns of the use of these medicines so that you identify when they may need prophylactic therapy, and then you monitor the side effects that they're experiencing from the prophylaxis as well. Abortive medications are those medications that we talked about in the first part, things like ergot alkaloids, Nsaids, what were the other ones we mentioned? Give me a minute. Abortive medications, the opioids, triptans, ergot alkaloids, and analgesics. Okay, abortive means that it stops the ongoing migraine. Okay, preventive or prophylactic are those ones we mentioned in the second part, saying that where we talked about beta-adrenergic antagonists, antidepressants, anticonvulsants, and also some Nsaids as well, right? So we have those medicines that are used as preventive, and then those medicines that are used as abortive to abort a migraine. So with this, let's take a few questions before we call it a day. Any questions? Anything that seemed unclear or that you want me to talk about before we close this lecture?
Sir,
Yes, go
Are we
ahead.
supposed to know the all the pathways that the each drug used to act on a particular each effect of each drug as a pharmacist to be able
Yes,
to give clinical advice and stuff like that?
yes. But you don't have to cram them. As a pharmacist, you'll always have your official books available with you to confirm those mechanism of action, side effects. Sometimes when you're rounding with a medical team, you can also use drug activity checker or drug interaction checkers, right? To you will need to you can use some of these tools to get what's it called, so you can advise the medical team on the appropriate medication to use and appropriate dosing as well. But as a student, you will need to know it and commit some of them to memory. The minimum, the minimal, the minimum that's expected from you is that at least you know the mechanism of action and side effects. That's very, very key for you as a pharmacy student. I hope that helps.
Sir, what about the interactions? We don't need to know them, sir.
No, not now. I hope that works. Is there any other question or is that it? Is there any other question?
So,
Yes.
mine is just like a comment, possibly because during the class, there were many things we were saying that I was not understanding because it was ambiguous and I was not understanding the terms, most of the terms.
What terms?
Like when you were explaining NSAID and you mentioned something like PUD, something like that.
That's peptic ulcer disease.
Oh.
Yes. Any other questions? Okay, I understand you. Like I said, I will send the links to the recording. Niren, do you have any question?
Somebody's mentioning him in the class. Okay, my mic.
Okay. With that, we've come to the end of the class. Please expect, I will send the link to your class rep. I do not have the list served for the class at this time, so I will send it to your class rep and then your class rep will share to everyone. Yes, you can get the slides today. But I mean, the recording, I would have to download the recording first and then I don't know, but I know by tomorrow though, you'll get that. Thanks everyone. Have a good day. Bye.